Gupta in this webinar. So he's a pioneer in the interventional cardiology in India. So Dr. Rajiv Gupta chairs the Preventive Cardiology and General Medicine departments in Eternal Hospital, Jaipur. And he also holds the chairman position of academic and research of the medical sciences in Rajasthan University of Health Sciences. So he has a very extensive experience in research and especially in the field of preventive cardiology. And on the academic background, he has done a MD from PGIMR and also holds a PhD in social and preventive cardiology from Medical College Jaipur. And he's, as I told in the beginning, he's one of the pioneer in the field, and he established among other credits, he established the first cardiovascular epidemiology laboratory, research laboratory in the non-government sector in India. And to his credit, he has published more than 1,000 research papers and book chapters, and notably, this research, several of them holds the top ranked journals like Nature, New England Journal of Medicine, etc. So it's my fortune to welcome Dr. Rajiv Gupta for this session, who will be talking today to us about the polygenic risk score, and the CAD risk prediction. Welcome, sir, please.
So thank you very much, and welcome everyone to this wonderful session. It's an important subject now, and I think it's emerging because now we have an epidemic going on in our country. So I'll start with a small case presentation. This is a patient I saw in the year 2002. Came to me with inferior wall infarction, complete heart block. We put in a pacemaker, thrombolized him. No classical risk factors. There was a family history of premature coronary artery disease. Coronary angiography showed extensive disease in the right coronary artery. You can see it here, actually, and in the left antidescending artery here. And he underwent angioplasty, pharmacotherapy, and he is doing all right. The question is that could we have predicted the risk in this young person? We all know that there are multiple risk scoring systems. We have clinical risk scoring like Framingham, Reynolds score of the European Society of Cardiology. We have Q risk 1, 2, 3 from the UK. Globally, we have WHO risk scores, the global risk, the inter-heart risk score. And then there are bioimaging risk scores like calcium scoring and plaque scoring and angiography. And finally, we'll talk about the gene risk score shortly. So what we did was to apply the risk scores to this particular patient. And what you see clearly is that all these risk scoring systems failed. They're showing the risk score of about 5%. Some even show less than 1% 10-year risk. So clearly all the risk scores do not work in premature coronary artery disease. Now the problem is all the risk scores begin at the age of 40. And in India, we all know that the disease is prevalent in younger people also. So I think these risk scores may not be useful for us. That's not only true for India. I think this is a study from the US and what from the Harvard young MI survivors. Young MI, less than 50 years, almost 1,600 patients. And if you look at the risk scoring system, either by the AACC, AHA guidelines or by the American Preventive Task Force guidelines, only half of them would have been candidate for statin. This is the primary prevention drug. So clearly, none of the risk scores predict risk in young people. We all know that cardiovascular disease is multifactorial. We have multiple factors. This we wrote in the Lancet some years ago. And what we highlighted was the genetic risk scores are very important because genetic endowment, natural environment, structural environment, and behaviors, all these things combine together to form a cardiovascular risk. In another study, what we did, this is a prospective urban-rural epidemiology going on all over the world. In India, about 33,000 people, and 11-year follow-up. What we found was, yes, we all know that risk factors were important. Hypertension, non-HDL cholesterol, diabetes, education, obesity, pollution, tobacco, everything was important. but almost a third of the risk was not explained by any risk factor. I think even at the young age, or even in the Indian population, the risk score systems do all right in some people, but not in all people. So there are other causes, genes and epigenetics. So we don't know about in one third of these patients. Gene and coronary artery disease is a very old story. When we were students, coronary artery disease was not as common as it is now. But whenever we used to see a young person, our teachers used to tell us that it's all genetics. Maybe we should look into that. Just it was a very primitive sort of a thought, although family history was important. Only in the late 90s and now in the last this century, we are trying to identify genes using technology. Uh, there are about 42 GWAS locations. These are the significant ones in the earlier years. And now more than hundreds of genes are implicated in coronary artery disease, lipids, inflammation, blood pressure, coagulation, platelets, multiple functions. So clearly you see that genes are important and they work through different mechanisms. In South Asia, there have been a number of studies which have tried to find what are the important genes. Unfortunately, no single gene predicts coronary artery disease in our patients, also in South Asia, nowhere in the world. So clearly, we need to look beyond a single gene disease. CAD is not a single gene disease. There are multiple risk factors. So then that's why the concept of the gene risk score came in the late 2009s and 10s. And the first paper coming out of it was a combination of multiple studies. What they did was these people from Finland and Harvard, they combined together to produce a case control study. And what they found was as the gene risk score, they combined 13 genes. As the gene risk score goes up in these particular cohorts, from one is low risk quintile, 5 is the high risk quintile. And as the gene risk goes up, the risk of coronary artery disease goes up. So clearly you see that the gene risk score was predictive more than the low gene risk score. Then there came a fashion of 60 gene risk score. This was again developed in the Harvard, Amit Khela and his group, Shekhar Ketharesan. And again, you see they combined so many genes and they applied the gene risk score to at least two communities, the atherosclerosis risk and communities community and the women's genome health communities. And in all these three, if you have a high hazard ratio, if you have high gene risk, you have a high hazard of coronary artery disease over a follow-up of 15 years in both of these cohorts. So clearly, if the gene risk score is high, that is in the upper quintile or upper tertile, you have higher coronary events over the follow-up of 10 to 15 years. So these were predictive, and from 13 gene risk score to 24 to 60, then you go on to 49,000 gene risk scores. Again, they study Framingham heart disease cohort and the Finn risk cohort. Again, they find that in the highest quintile of the gene risk score, the disease occurs at an earlier age as compared to the lowest quintile. So clearly, the importance of gene risk score was continuing. Multiple studies again continuing, 50 variants, 49,000 variants, 116,000 variants, and then 6.6 million, which is now known as the GWAS or the Genome-Wide Association studies. So they calculated GWAS score using 6.6 million SNPs or single nucleotide polymorphisms. And what they found was it was an odd ratio of 1.67. That means if you're in the highest bracket of this gene risk score, you almost 1.5 times to 2 times greater chances of your developing heart attacks. What they found was that genome-wide risk scores for common diseases identify individuals with risk equivalent to monogenic mutation. We all know that in coronary artery disease, the monogenic mutations like LDL cholesterol gene, for example, are important. If you have a LDL receptor abnormality, you have familial hypercholesterolemia, you have extremely high risk of developing coronary artery disease, premature coronary artery disease. And what they showed was, in this particular cohort study, that if you have high gene risk score, the risk is the same as monogenic or familial hypercholesterolemia. So clearly showing that all these three cohorts showing that if you have a gene risk score of a high degree, you have very high risk if the polygenic risk score was in the 90th to 100th percentile. So clearly showing that uh, high gene risk score is almost like a familial hypercholesterolemia, and we need to treat them as early as possible. There have been some suggestion that population-specific disease genes could be found in South Asia. And South Asia, I think, is the hub of the coronary artery disease, especially premature coronary artery disease in the world. And what we did was, in this particular study, multiple sites were involved in India. So this is the only Indian study which has shown importance of the genome-wide polygenic risk score in South Asians. Multiple sites, Bangalore, Chennai, Jaipur, and other sites were involved in this data collection. In the first phase, what we did was the validation of these cohorts. So in validation, 1,500 South Asian reference population, and we developed a genome-wide risk score using the ancestry adjusted polygenic score. And to make it slightly simple, two cohorts were in which this thing was validated. One was the UK Biobank South Asians, and you clearly see as compared to controls, if you have a patient with coronary artery disease, the gene risk score is higher. Similarly, in the Bangladesh study, you could see that if you have cases with coronary artery disease, the risk was higher. And there was a stepwise increase. So if you have low risk, 20th percentile. If you are in the top 2.5th percentile, the risk was almost 5.5 in South Asians. So clearly, in Bangladesh, South Asians, the risk was very high. And this is the Indian patients, 1,800 patients with coronary artery disease, 1163 controls. And what we saw in this particular study was that this genome-wide polygenic score, as the quintiles went up, the risk of ischemic heart disease or the acute coronary event went up. And if you are in the highest quintile of genome-wide risk score, the odd risk was almost 4. So clearly showing that high gene risk score translates into high coronary artery disease events, even in the Indian population. So what we did was to calculate the genetic risk score in this our patient, what we are seeing here. And once we do a risk scoring in this particular patient, he was indeed 90th percentile. So clearly, when all the other risk equations failed, the risk score equations suggested that this particular patient was in 90th percentile. And what we could have done was that we could have started him on preventive measures, healthy lifestyles, and statins, so that we could reduce the risk. But that was he had a heart attack 20 years ago. That time the information was not so complete. But now if you find a young person with some suggestion of risk, or as at a screening, you find that the risk score is in the top 10, 90th percentile, it will be wise to put them on preventive lifestyle and therapy. We all know that premature coronary artery disease is rampant in our country. Every day we hear people and young people and young people and men and women both dying suddenly. And one of the important cause is uh, acute coronary event. Again, in the UK Biobank, you see these red lines is all early myocardial infarctions. So in the UK Biobank, what you can see clearly is that if you have a early myocardial infarction, the gene risk score is higher as compared to the usual MI or ischemic heart disease. So clearly, gene risk score was predictive of early acute coronary events in the UK Biobank. And again, the same thing in the same UK Biobank is a different kind of study. What they did was to MI risk from the high polygenic risk score. And if you are less than 50 years of age, you have a very high risk as compared to if you are older person in the with the same risk score. And it has been validated across the globe in all ancestries, African, East Asians, Europeans, and South Asians. Although the number of South Asian people are small, but again, clearly showing that as the gene risk score goes up, the chances of the risk of ischemic heart disease also goes up. We have been doing a study on this polygenic score in our patients in Jaipur, and this is a data of 1,000 patients. We have just started to analyze the data and geographically confirmed coronary artery disease. We classified them into 4 age groups: less than 40, 40 to 49, 50 to 59, and 60 plus. And then we used the 6.6 million S&P based genome-wide polygenic score for classification into average, moderate, and high risk groups. And what you see clearly that even in these patients, about 21% people had high risk, 33% had moderate to high risk. So more than half of these patients are at moderate to high gene risk, clearly showing the importance of gene risk score. And when we classified based on age, what you see is in less than 40 years of age, the odd ratio was more than 2.5. So clearly you see that if you are a young patient with coronary artery disease, the gene risk score is high. And as we go on, we'll try to follow up these patients and this to see if there are any recurrent events occur more in patients with the high gene risk score. So with gene risk, we come back to our patient. How do we identify premature coronary artery disease? Which risk score is ideal for Indians? There are clinical risk scores which are only validated in Caucasians, not in India. They are widely used in practice. We use the entire risk score in our own study, the prospective rural epidemiology, the PURE study. And there again, it failed in 1/3 of the patients. The gene risk scores, although they're only validated in Caucasians, they are scientifically appealing. What we have shown that they are applicable at young age, although we need more studies and the costs are rapidly decreasing. The question which comes to mind as a clinician is, if there's a high genetic risk, so what? Can we do some intervention? Because genes are genes. We can't do gene therapies. We can't change genes. So how can we intervene? And clearly, I think we have evidence now that the gene risk score can be reduced by 40 to 50% using aggressive lifestyle interventions and statins. Now, these are data from the Harvard studies. This is the paper from Harvard, atherosclerosis risk in community studies, women, malmortality in the Finland, clearly showing that if you lead a very healthy lifestyle, you can reduce the risk to low risk. So if you have high genetic risk and you lead a healthy lifestyle, you can reduce the risk. Similarly, in the statin trials, the Jupiter, Ascot, CARE, and Prove-It-Gimme, if you have high gene risk and you are on statins, you can reduce the risk. And it was shown across all these 4 trials that in spite of high risk, high dose of statins can prevent future coronary events. And there's a trial going on known as Genova, the gene in the US. And what they see is that it's a pragmatic randomized controlled trial of GRS to prevent CAD, diabetes, atrial fibrillation, and cancers. They have a questionnaire recruitment, classifying them into high risk. If you are high risk, then they classify into usual care or interventions. And interventions is you talk to the patient, focus on him, give him advice for aggressive lifestyle. We still wait for the data to come out of it. So in conclusion, my friends, premature coronary artery disease is a major problem in our country. The risk scores like Framingham, the ACC-AHA, the score, the Q risk, do not provide adequate risk assessment in young individuals. The gene studies have identified numerous SNPs as important. The gene risk score using 20 to 200 genes have been developed, and they provide better prediction than family history and risk factors. And then the GWAS, the Genome-Wide Association Study-Based Risk Score with more than 6 million has been developed and assessed and validated in multiple cohorts, including our own cohort in our country, and they provide robust risk assessment and add to precision medicine for suitable interventions, especially lifestyle changes and statins, especially in the young. This is the method that we do it. We just require blood collection, DNA extraction, calculation of gene risk score, and then we classify into risk, high risk group for primary prevention, intermediate risk group. If they have some more risk factors, you again for primary prevention, and then you can classify into low risk group. Thank you. Thank you very much for your attention. Thank you.
Thank you very much, Dr. Rajiv Gupta, for the enlightening talk, very detailed on the technical aspects as well. So please be free to ask questions.
Yeah,
Dheeraj, you can. Yeah.
yeah. I'll just we have received few questions. So out of that, one question from Dr. Murlidhar sir. He was just wanted to know to what extent the cloud and AI data can be used on this research studies so far conducted, including the latest Jupiter study, sir. Rajiv sir, your take on this.
See, we are going towards the artificial intelligence technology in healthcare as well. If we combine the clinical and the genetic data, we can predict much more. I didn't show the slide, but there was a slide that the best way to predict coronary artery disease now in the era of AI is to combine clinical variables like the anthropometry. We all know the risk factors that we discussed in one of the slides. So we combine the risk factors and then also combine the risk score. And I think AI can help us here that because the genetic score is a very complex area, and unless you use AI technologies, you can not do that. But I can only suggest, I can only warn you against the predictive capabilities of the AI because still AI is in infancy as far as the healthcare prediction is concerned. So to make predictions, we'll need a randomized trials, and I think the latest, the Genova trial, which I showed you, is based on the AI technology.
Thank you so much, sir. So another questions we have received from Sayali Singh. She wanted to know, sir, how to measure genetic risk score and what parameters you can consider in risk prediction, sir. Like if it's polygenic risk score and how much it is relevant actually in today's scenario, sir.
So I think the first step is to identify people at risk. Now, people at risk identification, especially young people, how do you identify them? So they may have some associated factors like obesity, like abdominal obesity. They may also have family history of coronary artery disease, or you may have a slightly or borderline situation. The cholesterol is LDL is about 100, 110 or 100, between 100 to 130. There you think that whether to start this person on aggressive lifestyle or drug therapy, that's the question. And in these people, young people, it is very wise to do a gene testing, which is a very simple test now. You just get the blood test, sent to the lab, I think they are, and then they will give you the result, high risk, average risk, low risk. If it's a high risk or a moderately risk person, it will be important to teach the patient at least that please start aggressive lifestyle control, smoking, healthy diet, regular exercise. And if the LDL cholesterol does not come down with that, put him on statins. There are only two things as of today that we know of. In the future, we may be having more preventive armamentarium. There are lots of trials going on in the era of GLP-1 receptor, the obesity management, uh, agonists and all those things. So there are lots of trials going on in that area, but we still can't say. Right now, we only have two interventions which have been shown to be useful, healthy lifestyles and stress.
Uh, Thank you so much, sir. Another questions we have received is related to polygenic risk score only. Says the participant wanted to know, sir, is PRS is an absolute risk or relative risk prediction, and which risk tool is better for predicting CAT risk? Sir? Is relative risk reduction or absolute risk, sir?
See, the ideal situation in the ideal world, it will be absolute risk reduction. So if the risk is, for example, 10%, we would like to bring it to 0%. So that is absolute risk is from we reduce absolute risk by almost 100%, which is I think it is a utopian dream. We can't do that. So I think in clinical medicine, what we talk is a relative risk reduction. Gene risk score or the PRS is also a relative thing. Low risk, that means low gene risk score versus high gene risk score. We classify them into grade 1, 2, 3, high, moderate, and low, average, moderate, and high risk. So there are 4 categories. And then if the person falls into moderate or high risk based on the gene risk score, we institute preventive therapies. So I think as of today, we talk more of relative risk score, but I agree with you that the absolute risk reduction is the more important strategy.
Yes, sir. That's a very thoughtful answer from your side, sir. So another query is like, should everyone get a PRS test for cats, sir? Like, if there is any criteria, like above 18, sir, 18 years of age, if people attain, or like, so your take on that, sir?
So my take on that is a mixed bag actually. So one is clinical genetics is evolving, and clinical genetics. I was talking to our colleague. She's a postgraduate in clinical genetics. And I think even in the clinical genetics program in our country, there is very little focus on preventive genetics. So what we are talking of population and preventive genetics is a slightly looking into the future. And this is about, say, 5 or 10 years away, 5 years maybe away from us, although it may come even earlier. So now we can predict that a person is a high risk, and if he takes precautions, he can prevent disease. So, for example, I talk of a different scenario. If you have a disease for breast cancer, for example, the gene for breast cancer, and there's been a story of BRCA1 and BRCA2 genes, and it doesn't manifest in everyone. Even if you have BRCA1 or BRCA2, even if you are homozygous for that, you may never develop breast cancers. So there are protective systems going on. So, but coronary artery disease, fortunately, is not a monogenic disorder; it's a polygenic disorder. And when you have a polygenic disorder, you have polygenic risk score. So we can never be sure that you are going to develop a disease. We can only talk to the patient that is a risk of disease. That's like we talk of hypertension, we talk of cholesterol, that not every person with hypertension is going to develop stroke, for example. So I think we have to be careful when we are talking about this. And I think as things evolve further and further, preventive genetics will be more important for our undergraduate and postgraduate students. And then they will be able to guide the patient that how to employ gene risk score in clinical practice. I think for me right now, also as a treating physician, I think for me it is important that I talk to the patient before advising him genetic risk scoring system and tell him that if your risk is high, we can offer you something. Don't tell him that if the risk is high, we can't do anything. That's not the right way of doing it. Do the thing, do the test where you can intervene. Never do a test where you cannot intervene.
True, sir. Very true, sir. Sir, one very interesting question we have received. If the person is on statin therapy, so is it good to go for the genetic testing for PRS straight away, or like they need to check for the family genetic evaluation, sir? So, your
So I think both ways. If a person is having familial hypercholesterolemia, if his LDL cholesterol says 190 plus, it will be useful to do a cascade screening. That means you have multiple, you screen all the family to find out, to capture young people with the high risk of coronary artery disease. In the same group, you could also do a gene risk score. So a person is convinced that it is not only LDL, but I am also risk beyond LDL by other genetic mechanisms as well. Because in the gene risk score, you have inflammation genes, you have thrombotic genes, you have blood pressure genes, diabetes genes, multiple genes. So even now you have tobacco and physical activity genes also. I think you have multiple genes in the gene risk score. So clearly, if you tell him that you have a risk beyond LDL, it's likely that he will listen to you better and he will be amenable to stick to this statin therapy all his life.
Thank you so much, sir. Sir, we have a question from Dr. Thelma, sir. She's a renowned scientist in India, and I'm very happy that we are very happy that she joined for the session. So she had a very interesting question from her side, sir. Can you clarify like how 20 to 200 genes provides a more effective predictability compared to the familial cases, which you assume like would have far fewer number of genes but of major effect?
Uh, I think it's important to realize that there are genes with variable penetrances available, I mean, in our system. And I think if the gene is a rare variant with high penetrance, like happens in some cancers, some obesity, some things. So if you have genes with high penetrance, a single gene can explain lots of diseases, which is like almost monogenic or duogenic or whatever you have. Unfortunately, coronary artery disease, if you keep on increasing genes, the risk, the additive value of the combining multiple genes is higher. And we clearly saw that if you have 20, 12, it began from 13 genes and went on to millions of them. So as you combine more and more genes, you tend to be more precise in your prediction. So I think it is just like a precision medicine that you are getting more precise using more genes as compared to less precision with less number of genes.
Yes, sir. So very thoughtful, sir. And sir, another one question. So we'll take another two to three questions, sir. So another question is, what is the significance and role of epigenetics in the initial screening of cats, sir, or in the conjunction with the genetic exome sequencing? I think this question came from Dr. Murlidhar P. Sir.
Yeah, I think epigenetics is important. There is no question about it. I think we all know that even if you have abnormal gene and gene doesn't function, so the gene penetrance, epigenetics or the gene methylation also leads to changes as far as the gene function is concerned. So I think the gene is only a single first step. Ultimately, we'll need proteomics, we need functional genomics and multiple technologies to identify how do these things work. And I think epigenetic systems are again very important. I think importantly, I think epigenetics, aging, and all the which are there. Atherosclerosis is ultimately a disease of age, premature aging, if you can call it. But I think all these things are combined, and I still await more studies on epigenetics and the risk of coronary artery disease. There are very few of them right now.
Thank you so much, sir. Like the session was really great, actually, and a lot of thoughtful queries has been answered by you, sir. Actually, a lot of people are asking in the chat, is the webinar is conducted by MedGenome, and they were just asking like if we are offering any test. So, as we all know that we are having a test, Cardiogen is a preventive genetic screening test. So, sir, your take on that Cardiogen, sir? Like they were asking for the query, so just I thought of asking you, sir, on that.
Yeah, I think ultimately we'll need a gene score which is well validated in our population. I think uh, there are, I mean, MedGenome has developed its own gene score. It has spent funds or money to 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 study, to evaluate all of them. I don't get any, by the way, I have no conflict of interest with MedGenome because they don't pay me anything on this aspect. So I can tell you that ultimately there might be two or three more companies who have a gene risk score. But what we need to realize is that we need to use a validated risk score. And I think as far as MedGenome, I think is the only one which has a validated risk score for our patients. People have gene, I mean, people are not doing it's a high technology affair. And I think unless you have a well validated standardized lab, and there could be more than one, you should use it.
Uh, Thank you so much, sir. Sir, one last question they like I have received it, and that is like on the price concern, sir. Because like people are assuming that genetic testing normally comes with the cost. So that is one myth like we are requesting like to be busted from your side, sir. Like how the
No,
genetic screening.
I don't know the cost of it, so you have to answer that question.
Yes, sir. No, sir, is the cost is a concern about it, sir? That's the question came up, sir, for this.
See, I mean, you right now, what do we offer for prevention? One is we offer a clinical history, so a careful physician who is trained in preventive medicine or preventive cardiology, listen to the history of the patient, ask about the family history, look at the risk factors, and then try to estimate the risk. So that's how clinical medicine works. And if we have some more technology, not very expensive, I mean, if you measure, for example, lipids, you measure LP little a, lipoprotein A, which is available now. You measure other biological risk factors. It has a certain cost. I think this cost and the gene risk cost is almost the same. So I think once you can combine all of them together, the cost is not very high.
So very interesting take, sir. Your feedbacks are really important for the upcoming clinicians, like who would be opting for this, the genetic risk score, basically for identifying cat. And Dr. Ramesh Menon, sir, I request you to just say a few words about the session, and then we can close it, sir.
Yeah, it was really going deeper into the the studies, slightly covering on on the real technical aspects also. I really appreciate, as a very well experienced clinician and a researcher, a scientist, eminent scientist. He's again, Dr. Ajay Gupta is one of the, you can say, top 1%. In the country, he, in terms of all the output, its contributions and all. Yeah, he participated in he was there in the study where we collaborated, with Dr. Rajiv Gupta also. So it was a really, really, enlightening talk. And there are several questions in the chat box that people are asking about the things. You can always get back, on if you have specific questions. We will, we can send it to Dr. Rajiv Gupta and get the answers, to your questions.
Sir, because we received almost 60 to 65 questions, sir. So that's what we were selecting the questions like which will be like more relatable to your presentation. And sir, thank you so much, sir. Once again, really thankful from MedGenome, and we hope, sir, we'll be connected again, and your talks would be like providing fruitful things to the participants. Sir.
Thank you.
So a very good night, sir, to you, sir. Thank you.
Thank you.
And thanks everyone for participation. Thank you, sir. Thanks, Dheeraj.
Thank you, sir.